type of topics. Now this time, this is going to be very important essay. Actually, I'm going to discuss 2 essays and 1 short notes, and sometimes it can be also come as a long case like an obstructive jaundice. So it is an important topic in my opinion, the gallstone disorder. Like every time I keep telling you these 3 points, you may be wondering it is a repetition, but this is just to make your understanding of surgery very easy. Every time when you have a patient, you have to imagine the patient is just lying or sitting in front of you. So you need to visualize a patient of biliary colic, acute cholecystitis, or a case of obstructive jaundice. So that's the only way you can understand these pathologies, because at your age, at your stage now as an undergraduates at the final year, you wouldn't have seen that many number of cases of patients presenting with either biliary colic or acute cholecystitis. So it takes a lot of imagination from your point of view, but I can give you some hypothetical cases for you to understand. But even there, I think what you need to, all of you should have is a symptom-based approach. If you have a patient with upper abdominal pain, okay, especially I told you, any pain in the epigastric region is a pain. If it is a visceral in origin, it is a foregut pain. So any organs developed from foregut, okay, either it is esophagus, stomach, or in the first and second part of duodenum until the ampulla vata, that is a foregut, isn't it? That is all the viscera developed from the celiac plexus. See, celiac artery distribution, if you know, those are the organs developed from the foregut. So you need to understand, and also it includes liver and gallbladder also. Okay, so with that all in your mind, you have to understand. So here the gallbladder also will give rise to a foregut pain. So let us go on to our first important topic of today, that is how you manage a case of gallstone, cholelithiasis. Then how we operate on a patient with a gallstone. Of course, it is laparoscopic surgery. So here itself, today, we spent about 20 minutes or so to understand the steps of laparoscopic cholecystectomy and also the benefits and the risks of laparoscopic surgery. Third, a short notes very often. Sometimes very important in the viva, they'll ask you various things. How will you diagnose a case of obstructive jaundice biochemically? What is Charcot's triad? What is the Reynolds pendant? Things like that. Or what is Murphy's sign? All those things they'll be just asked. They give you only just a few seconds to give you an answer. So you should have a clear-cut understanding of all these common problems. So today's class, that way, is very, very important. First, to understand the genesis, how the gallstones are produced. What are the complications of the gallstones? Not only in the gallbladder, but also when it comes out of the gallbladder into the bile duct and travels its way. All those things we are going to discuss now. Before we go anywhere, the foundation is important. That is clear understanding of anatomy and physiology. This is a little diagram to show you the extrahepatic biliary tree. They'll ask you, tell me the anatomy of the bile duct or biliary tree. You have to be very, very clear. Ideally, in an essay, you just draw a nice diagram and annotate with your all the which is what. But if it is asked in the viva, you tell the bile is produced in the liver, and it comes out of the liver through the right and left hepatic duct to form the common hepatic duct. The common hepatic duct joins with the cystic duct from the gallbladder to form the common bile duct. So what is the function of the gallbladder? Whatever the bile secretes here, it goes inside the gallbladder, gets stored, concentrated, and whenever there is a fatty meal you take, then there is a relaxation of the sphincter, contraction of the gallbladder, and drainage of the bile, the concentrated bile from the gallbladder. That's the only thing. So the gallbladder is storage and concentration. That's all its function. So the cystic duct joins with the common hepatic duct to form the bile duct. The bile duct, watch me, we have four important parts. That is supraduodenal, retro, that is behind the duodenum, retroduodenal, then intrapancreatic, intraduodenal. You have to watch all these four important. Out of that, the most important thing, of course, is the supraduodenal, that is just above the first part of the duodenum. Why it is important? Because this is the area of the common bile duct where we make a small vertical incision in the bile duct in order to remove the stone in the bile duct. That is called choledocolithotomy. So they'll ask you a simple question. What is choledocolithotomy? Choledoco means bile duct. Lithotomy means removal of the stone. So the removal of the stone from the bile duct is called choledocolithotomy. Where it is done, it is over the bile duct. Which part of the bile duct? It is the supraduodenal part of the bile duct. What type of incision we make? Because it is coming like this, descending down. You make a vertical incision and open like a book and then deliver the stone out by using a catheter called Fogarty catheter. Okay, so these are the things we are going to discuss later. So the bile duct, when it drains at the ampulla vata, which is present in the junction of the, the foregut and midgut, that is at the medial wall of the second part of the duodenum, the ampulla vata, wherein the bile duct opens, and it has a common channel along with the pancreatic duct. The pancreas, incidentally, which is present within the C lobe, is having a drainage to the main pancreatic duct, which drains into the duodenum through the duct of Wirsung, duct of Santorini. The duct of Wirsung, which joins with the main, that is the common bile duct, at the sphincter of Oddi. Okay, this is sphincter of Oddi or ampulla vata. Duct, this Santorini, duct of Santorini, opens at the minor papilla. This is minor papilla. This is major papilla. Major papilla is the place where most of all the bile, most of the pancreatic juice drains. That you should know. And where is minor papilla? It is about 1.5 centimeter above the major papilla. So you should know both are on the medial wall of the second part of the duodenum. So that's all the anatomy you need to know at your level. Repeat, keep on rigorous, because they'll invariably ask you to draw in the exam, especially if people like me are going to be the examiner. Next, they'll ask you a simple question. Why do people develop gallstone? Simple thing. Why people develop gallstone? Okay. Why people develop renal stone? That's all because of the imbalance. Because normally it is not our property, that is either in the urine or in the bile. We never form stones. Only if there is some mismatch or imbalance happens in the concentration of the bile acid and cholesterol. In other words, if there is excess cholesterol in the bile, less amount of bile acid pool in the bile, then the bile becomes what we call a lithogenic. So you tell the examiner, sir, the bile, which is normally liquid, it becomes lithogenic, that is propensity to form stone whenever there is an excess of cholesterol or decreasing bile acid. Okay, tell me where all you have a decreased bile acid pool. For that you have to understand the bile acids are produced, okay, from the liver, and it comes to the bile duct, and as it goes in the small intestine, it is not, because we have only a small amount of pool. It never gets wasted going into the colon or fecal excretion. If you see the fecal excretion, it is only 5% of the pool. Most of them, close to 95% of them, go for what we call enterohepatic circulation. Very, very important. In other words, as soon as it does the part that is helping in the digestion of the fat and also fat soluble vitamin. These are the two important functions of the bile acid. As soon as they do that, they get reabsorbed actively, very important, not passive, actively ileally, in the terminal 2 feet of the terminal ileum. Okay, and then they go through the portal circulation back to the liver. Again, they go for the same circulation. So in other words, they go for this short circuit, so they never get wasted. That is a very important thing. This is a one way of body's mechanism to preserve the amount of bile acid secreted in our body. Imagine there is one condition, one pathology like a ileal tuberculosis or Crohn's disease affecting the terminal ileum, or if you have some surgery done either for tuberculosis or Crohn's disease where you remove the terminal ileum. In those conditions, with the absence of terminal ileum, you will not have the enterohepatic circulation. Those two people will have two important complications. One, of course, they lose their bile acid pool and they'll develop gallstone. That you know now. The second thing, you know what will happen? All of you, please understand. They also will develop macrocytic anemia. What is why macrocytic anemia? You know, there is an intrinsic pathway and extrinsic pathway. Okay. So there is an intrinsic pathway and extrinsic pathway, you know. So this is here, there is a B12 absorption depends upon the intrinsic factor and also extrinsic factor. So in the problem either in the stomach or in the terminal ileum, there will be some malabsorption of B12. So B12 malabsorption also can happen if there is a terminal ileal disease. So because of these two problems, that is both bile acid pool and also B12 deficiency will happen in a patient with a terminal ileal disease. Okay, let us move on to the next important thing. That is, what are the different types of the gallstone? Okay, so what are the different types of the gallstone? Cholesterol stone. Okay, just let me just wait. Okay, cholesterol stones, pigment stones, and mixed stones. So the cholesterol stones are pure cholesterol stones are very unusual. Same way, pigment stones are very unusual. The commonest stone, gallstone, is a mixed stone, 80% of them, like this. Faceted stones. Okay, I can see the whole gallbladder is loaded with stones. Okay, but when the stones develop, they usually are cholesterol, then slowly, because of the pigments, they become a mixed stones. Pure pigment stones can happen in people with the infection in the biliary system. Can we give any examples? Yes. One example is a patient with hemolytic anemia because of the bilirubinate can get accumulated. The second important incidence is patient with worm infestation like Clonorchis sinensis or liver fluke. Okay, if it's in the CBD, bile duct, it can cause infection. And also if any super infection in the bile duct because of the bacterial super infection, also you can have some stones. So Asiatic cholangitis. So those people can have some muddy-like stones, that is pigment stones. But in our country, the commonest stone is mixed stone. If you know that, that is well and good. Next important thing is, why do people develop stones? And what are the problems because of the stones? These are the two things you need to understand. Okay, there are actually, if you see this busy slide, there are at least 10 reasons why people develop stones. Okay, there are 10 reasons why you develop stones. What are the 10 things? That is age, gender, obesity. That's why we say any patient who is fatty, multiparous, fertile, female, especially the gender is of course female because of the hormonal changes, and 40, the age group of 40 to 50, that is the age group, middle-aged lady. So 4 Fs, they are notorious to develop the stones, especially the cholesterol stones, of course subsequently the pigment stones and also the mixed stones. So in addition to that, this is also for you, it is easy to understand, isn't it now? Because when you have a terminal ileal disease, there is a less amount of bile acid because bile acids are lost because of no enterohepatic circulation. both in the ileal disease like ileocecal tuberculosis, Crohn's disease, and also when you have a ileal resection for these conditions. In addition to that, people on the total parenteral nutrition or people taking drugs for hyperlipidemia like clofebrate, they are also known to develop this problem. And the diabetic people and cirrhotic people also known to develop these stones. And I told you already, pigment stones are quite common in people with hereditary spherocytosis like hemolytic anemia, or also in some case of cirrhosis or super infection with the bacteria like E. coli and bacteroids. So these are all the different causes. But if you don't know anything, you try to remember 4 F's and also terminal ileal resection and cirrhosis, because it is a liver disease. Quite often it is accompanying, and hemolytic anemia. Never forget these common things. We often see any one of these patients in day-to-day life. Okay, if you have a stone, what is an issue, you may ask? Unlike renal stone, where the renal stone, what it will cause? It will cause pain, that is a urinary colic or infection. But here, the problem of biliary stone or a gall stone is much more. Okay, this diagram will tell you or try to explain to you what are the possible complications one can have. Okay, one, these stones, especially when you start taking some fatty meal, when the gallbladder try to contract, the stone will move from here, and sometimes if they are large enough, they can get stuck in the cystic duct, the narrow portion. Because of that, the patient have severe pain because of the distance of the gallbladder with the bile. That is called a biliary colic. And whenever there is a stasis of the bile here, there is an infection. So cholecystitis, inflammation of the gallbladder. If this stone, if it somehow manages to find its way and enters the bile duct, it can cause obstruction to start with. So bile flow will be obstructed. So obstructive jaundice. In addition, stasis of the bile in the bile duct causes more serious infection, that is called cholangitis. That as the stone finds its way somehow to the common channel, it can cause obstruction to the flow of not only the bile duct but also the pancreatic duct. So because of that, it can cause reflux of the bile into the pancreatic duct and causes biliary pancreatitis. So these are all the various complications it can give rise to. So you need to know all these complications to understand. Okay. So here I enumerated every one of them for you to understand. Okay, biliary colic, acute cholecystitis. But what about all these complications? Let me explain one after other. In other words, there are 10 different complications. So there are 10 reasons why we develop stones. There are 10 reasons why we should remove the gallbladder before it causes these complications. What are the different complications? Starting from number 1. First commonest complication is biliary colic. What is biliary colic? As I just mentioned, whenever you have a fatty meal, imagine like a potato chips or fried chicken or grilled fish or things like that, and if you eat, then you need a bile for digestion. So the gallbladder try to contract. The stone from there can sometimes get dislodged and go and get stuck in the cystic duct. Immediately you have a pain. That the pain is very classical. Upper abdominal pain, especially in the right upper quadrant, radiating to the right shoulder and also the tip of the right scapula, associated with few episodes of vomiting. And the pain usually lasts for 2 to 3 hours. It's not few minutes. Like an angina, usually few minutes you say, isn't it? Biliary colic, patient will be rolling with the pain for at least few hours. They never forget. They always afraid to take the next fish and chips, because every fatty meal could initiate this fatty dyspepsia or intolerance. Okay, so fatty meal, contraction of the gallbladder, cystic duct obstruction, initiation of the biliary colic, pain, especially in the right upper quadrant, radiating to the back, especially the tip of the scapula on the right side. Okay. And next thing is they can develop acute cholecystitis. What is the difference between biliary colic and acute cholecystitis? It is a progression of the disease. When there is a persisting obstruction of the cystic duct, you can imagine there is a stasis of the bile. When there is a stasis of the bile in the gallbladder, there is an infection. Wherever there is a stasis, infection can set in. Urinary tract infection, why it happens? When you have a prostatic enlargement, stasis of the urine in the bladder, then men can get cystitis. Similarly, here cholecystitis. What is the sign of cholecystitis or inflamed? So it is some sign of appendicitis is McBurney's sign. Sign of cholecystitis is Murphy's sign. So if anybody asks you, define Murphy's sign, you have to tell the examiner, sir, Murphy's sign is a sign of acute cholecystitis. That is the first word. How will you elicit? You just remember this picture. The patient is lying supine. I put my hand just below the costal margin along the mid-clavicular line. Then I ask the patient to take a deep inspiration. As the patient takes a deep inspiration, the diaphragm comes down as the lung inflates. Along with that, the liver and the gallbladder. And the descending gallbladder will touch my finger, and the gallbladder, because it is inflamed, the patient will have pain. So he'll say, as soon as he takes a deep breath, so he catches his breath. So he winces with pain or he cries with pain. It hurts, doctor. Whenever I breathe in, your finger touches something in my body and it gives me the pain. So pain on the deep inspiration or the peak of the inspiration, that is zenith of the inspiration, is called Murphy's sign. So you should be very, very good in explaining the examiner. Patient lying, deep inspiration. I put the hand, my palm, over the right, under the, just below the right costal margin, along the mid-clavicular line. Patient will have a pain on deep inspiration. Okay. What about the next three complications? Next is empyema of gallbladder, mucosal of gallbladder, and gallbladder perforation. What is empyema of the gallbladder? Empyema of the gallbladder is bag of pus. Empyema is a bag of pus. The infected bile, because it can, if it is a bacterial superinfection, especially diabetes, you can always tell if a patient is having a stone in the gallbladder and the diabetes, he is prone for empyema. The D, A, B, C, D leads to E, that is empyema. So that is a common comorbid condition causing empyema of the gallbladder. What about the mucosal of the gallbladder? Here, only a mucus secretion alone, distended gallbladder, only with the mucus secretion of the gallbladder. Why this happens? Very easy to understand. If you imagine, if the gallbladder is getting stuck with a cystic duct, okay, and the bile here gets absorbed over a period of time, and the bile from the bile duct goes straight through the common bile duct into the intestine, they never have and could find their way entering the gallbladder. So the gallbladder no longer receives bile. So what is inside the gallbladder now? Whatever is secreted by the lining of the gallbladder, that is a mucus, because there is a mucus lining cells. So mucus distended gallbladder. So it is a chronic process. After several months of persisting in obstruction at the cystic duct, the mucus secretion of the gallbladder causes a hugely distended, uninflamed gallbladder. So it is a large, non-tender swelling, a pear-shaped, okay, pear-shaped swelling in the right side of the abdomen, right upper quadrant, okay, which moves with the respiration. See, there are only certain organs in our body which moves with the respiration. Liver, gallbladder, spleen. What else moves with the respiration? If the swelling is arising from stomach and also omentum, and also to some extent, if it is attached to the, some slight mobility may be there in these things. But what will not move if it is in the pancreas, retroperitoneal structures. Okay. What about kidney? Yes, kidney, renal swelling also moves, but not as much as liver, gallbladder. So liver, gallbladder, spleen moves freely with respiration, and kidney moves only a little bit with the respiration. There are certain organs they don't move with the respiration. For that, classical example is colonic mass, small bowel mass, all those things. You have the retroperitoneal mass, they never move with the respiration. So you should know what are the things directly in relation to the diaphragm, they move with the respiration. Okay. Next is when the gallbladder bursts because of the persisting obstruction. Sometimes you have a perforation of the gallbladder. So the whatever is the content from the gallbladder, if it is bile, there is a biliary peritonitis can happen. Stone can fill and it causes additional infection. So this is a life-threatening complication that can also happen. What else can happen? Rarely, especially in northern India, if there's a stone in the gallbladder for a long time, then it can be a precursor for developing a gallbladder cancer. So they can develop a gallbladder tumor. And what is the finding that will indicate that you have a gall? The ultrasound imaging will tell there is a thickening in the gallbladder wall, or ultrasound or a CT scan, or you may use a tumor marker. What is the tumor marker for gallbladder cancer or a pancreatic cancer? If anybody asks you, you can tell that is CA19-9. Okay, I already told you few tumor markers. Let us recollect one more time. CA125, it is ovarian cancer. Good. Then PSA, that is prostatic cancer. Then what else we can tell? Serum calcitonin, medullary carcinoma, thyroid. CEA, carcinoembryonic antigen, that can be colonic cancer, and also here in the biliary cancer. So CEA, as you know now, it is non-specific. It is not always colonic cancer. It can also increase in other malignancies. One example is bile duct cancer. But in bile duct cancer, more important than CEA is what? CA19-9. Is there any other tumor markers? It's important at this stage. If you ask me, you better know alpha fetoprotein. Alpha fetoprotein increase in hepatoma, because patient presenting with jaundice will be having a doubt whether it is a liver cancer or bile duct cancer. If it is a liver cancer, they'll have alpha fetoprotein. If it is a bile duct cancer, they'll have CA19-9. Okay. So these are all the few things you should know. Okay. All of you, please unmute yourself. It's giving some disturbances my end. Please, students. Right. Let's go on to the next complication. That is what this is the very important thing for all of you understand is it can give rise to obstructive jaundice. I told you the stone here can sometimes find its way beyond cystic duct, the bile duct. So whenever you have a stone in the bile duct, the mother of the gallstone, or where it originates always from the gallbladder. In other words, 80 to 90% of the stone in the bile duct originates originally from the gallbladder. If you don't have a gallbladder, you don't develop bile duct stone, as simple as that. But having said that, there are about 10% of the people, rarely, they can develop stone in the CBD bile duct itself. That is called a primary bile duct stone. Give an example if you ask me. People in Southeast Asian countries, okay, they, because of the worm infestation like Clonorchis sinensis, okay, or Fasciola hepaticus, like that, if they have a worm, liver flukes, they can have an infection. So that is called Asiatic cholangitis. So they can develop primary bile duct stone without having a stone. But in our country, invariably, most of them, they'll have stone initially here, only then they'll have here. Isolated stone in the bile duct is very unusual in our country. First, you have to understand that. Okay. And okay, what is the problem of stone here? First, it can cause what is called because it will not cause like a tumor. It is unlike a tumor. This will be sometimes floating in the bile, or it will go down and get stuck here. So it will cause intermittent obstruction. Very, very important. In other words, the bile duct, so it will go and drop down to the bottom and cause obstruction. Then again it will float after some time. So whenever it goes, causes obstruction here, patient will have pain, fever, jaundice. Whenever it starts floating like this, the pain, fever, jaundice will be relieved. So the patient will say, doctor, yesterday night I had some meals. After that, I had a pain in the right upper quadrant, but in that I had some rigor. And I also went to the toilet, passed urine. The urine was a little dark in color. So he'll very physically, it is unlike a biliary colic. Biliary colic only will give rise to pain, intermittent pain. Will not have fever and also jaundice. So if you have the cardinal three symptoms, pain, fever, jaundice intermittently coming, like 4 or 5 episodes in the last 2 months, and like this patient, classically pain here, little icteric tinge, then you think of the Charcot. Charcot actually is a neurologist. He explained a lot of things, and one of the important thing is Charcot stride here, and another is a Charcot Mary tooth disease. Charcot's foot, that is a diabetic foot, diabetic neuropathic foot. So there are a lot of things he did. So his country of origin is France, French neurologist. If you remember that in the history, that is well and good for the time being. Okay. In addition, if the bile duct stone, if it is causing Charcot striate, sometimes the bile itself can get infected, and this causes a bacteremia, a portal pyemia. That is, so a severe infection of the blood stream. So patient will develop cholangitis and bacteremia or portal pyemia. So it's a very serious life-threatening condition. So they get hypotension and confusion. Why hypotension? Because the infection is usually because of the gram-negative organisms like enterobacteriae, like E. coli, Klebsiella, Pseudomonas. So they'll ask you, name some organisms which causes. So whatever organisms you see in the large intestine, that is the enterobacteriae, gram-negative bacilli. Give some example. Commonest infection in your urinary tract. If you have 100 people with the UTI, 70 people will have E. coli. Next is Klebsiella, then Pseudomonas. These are the three important things. And then in Citrobacter, there are other, things like a Staphylococcus, all these things will come. But these are the three common organisms. And E. coli is by far the important thing. Okay. Next, the ninth one is one of the life-threatening complication. If you have the bile duct stone coming right at the end, near the ampulla beta, and stuck at the what we call a common channel, then it causes reflux of the bile into the pancreatic duct. Then there is an auto-digestion of the pancreas. That is acute biliary pancreatitis. Pancreatitis causes for pancreatitis, if anybody asks you, there are only two important things you should see. There is A, there is alcohol, B, bile duct stone. If you know that, 80% of them will be solved. Of course, there are other things like a congenital things like a C, it will come. I'll tell you, the pancreas division, and also some conditions like a hyperlipidemia, metabolic causes also there. Drug-induced pancreatitis is there. So, okay, so tell me some drugs which can cause pancreatitis. Go and read. Okay, one of the important drug is azathioprine. So all of you homework is, what is azathioprine? In what conditions azathioprine or 6-mercaptopurine is used, and how it causes pancreatitis? What other drugs can cause pancreatitis? Is it any, scorpion sting cause pancreatitis? Okay, and also hyperlipidemia can cause pancreatitis. So all those things, autoimmune pancreatitis. If there are no causes, that you call it idiopathic pancreatitis. So there are humpty number of causes for pancreatitis, but there are two things in our country. Thanks to alcohol, that is the commonest thing. And of course, because of the bile duct stone, next common cause for pancreatitis. And this is the classical, the ampullator, the second part of duodenum, where a stone is stuck there, and unless you remove the stone, deliver the stone, it's like a baby's head stuck at the vagina. What do you do for the delivery of the baby? We do a procedure called episiotomy, isn't it? We make an incision and enlarge the opening and deliver the baby. That is what. Similarly, we can just incise this. That is called the division of the sphincter is called sphincterotomy. So the sphincter of OD is divided here, and then you remove the stone. That way you relieve the patient jaundice. Okay. And what is the diagnosis? How you make the diagnosis of pancreatitis? Classical history, and also pancreatitis is diagnosed by measuring either a serum amylase or lipase or both in the blood. If the level is more than 1000 international units, that is diagnostic of pancreatitis. What is the normal level? Normal level is less than 100. Normally we say 0 to 40. But if it is less than 100, you take it normal. More than 1000, it is pancreatitis. What about from 100 to 1000? $1 million question. That is otherwise called a pseudo hyperamylasemia. In other words, they are not classical for pancreatitis because there are some conditions can cause increased serum amylase level, but it is not pancreatitis. Give some example. If you ask me, I'll tell you, like a small bowel ischemia. One example I'll tell you now. There are other causes also, but we will discuss that when it comes to the chapter of pancreatitis discussed. So you go and read what are the other causes for increased amylase level between 100 to 1000. That is pseudo hyperamylasemia. That is a one homework for you. Okay. The last interesting complication of the gallstone is gallstone ileus. Okay, here is a visualize. Here is a gallstone lying in the gallbladder for more than 10 years. Like it developed when you are 60-year-old. Now you are about 75, 80-year-old granny. You have to imagine, and it is get bored because of that. What will cause is a recurrent infection, recurrent inflammation, fibrosis. So it causes the fundus of the gallbladder getting attached to the some of the part of the second part of duodenum. If you see the second part of the duodenum also in your right upper quadrant, okay, just below the gallbladder fundus. So this you develop a fistula that is called cholecystoduodenal fistula. So from here there is a connection. There is an abnormal communication between two epithelial lined structures, namely gallbladder and the duodenum. And because of that, the stone finds its way out. Because the stone is big, so it cannot go through the cystic duct. So it is waiting. Now after 20 years of long wait, it is free bird now. It will travel into the duodenum all the way through the small bowel, and then it will get stuck in the ileocecal valve because that is the narrowest portion of the small bowel. Then it cannot go any further. Then patient can present with small bowel obstruction. That is due to gallstone. That is called gallstone ileus. So if anybody asks you what is gallstone ileus, you tell gallstone ileus is an unusual type of small bowel obstruction due to gallstone which migrated from the gallbladder through a cholecystoduodenal fistula. See, that is one line answer. Okay. So I repeat, what is gallstone ileus? Gallstone ileus is a type of a rare cause for small bowel obstruction of the small intestine caused by the gallstone which escaped from the gallbladder through the cholecystoduodenal fistula. When the gallstone escapes this way, the air normally you have gas in the small intestine, isn't it? It will go this way. In other words, I always tell my student, the stone comes this way and the gas goes the opposite way. So the gas goes and fills the whole gallbladder and biliary tree. That causes a classical radiological condition called pneumobilia. Air is never present in the normal biliary tree. It is only present after two conditions. One, cholecystoduodenal fistula. Next is after a procedure called ERCP. Okay, what is ERCP? We are going to learn today. So this is a classical X-ray of gallstone ileus, wherein you see a patient who is having a air in the biliary tree. How do we know? You have to carefully look at the area where you normally see the liver. Liver where you normally look in the X-ray abdomen. In the right upper quadrant, below the right dome of diaphragm. Here usually liver appears as a white shadow. It's a dense. Okay. Whatever is black is air. Okay. So you can see a faint shadow. You have to believe me, is a faint shadow of the common bile duct, left hepatic duct, right hepatic duct, and a cystic duct. So this is air in the biliary tree. And from this gallstone enters the duodenum. This is the distant duodenum. And all this are gaseous, obstructed small bowel. And you see faintly a shadow here. There is a gallstone in the terminal ileum. So presence of air in the biliary tree, dilated small bowel with a stone in the terminal ileum, three cardinal radiological finding is called Rigler's triad. Rigler's triad is very, very important for you. Okay, for a MCQ. So I told you, if you are asked to write in the exam an essay on gallstone disease, you tell the 10 causes why people develop gallstone. Okay, I told you all those things. Then what are the pathology? I told you always risk factors, pathology, symptoms and signs, investigation, management, and then conclusion. This is the way we read all. So here also same way, we finished two major portions. Now coming to the third thing, how do they present? There is symptoms and signs. I told you the symptom is biliary colic. That is right upper quadrant pain radiating to the back with the vomiting. What is the sign? Murphy's sign. Any other sign? If they have a jaundice, that means they have already developed a bile duct stone. So these are the signs to look for. What investigations you do? Simple to more advanced investigation. Hematological and biochemical blood test I'll do, sir. What will you do? For example, you'll do a hemoglobin, white cell count, platelet. Any abnormality you see, if a patient has acute inflammation of the gallbladder, acute cholecystitis, what is the sign of inflammation? There will be leukocytosis, neutrophilic leukocytosis. That's what you need to tell. Okay. And urea sugar is important. Why important? Because diabetic people are more prone for gallstone. Diabetic people are more prone for developing a problem like empyema of gallbladder. So you look at the patient's sugar. Why creatinine and urea important? Because the renal functions are important before we do any surgery. If the patient's renal functions are bad, like creatinine, what is the normal creatinine level? Up to 1 is normal. Anything above 1 is abnormal. What about urea? 10 to 40 is normal. Above 40 is abnormal. Why I'm telling all these things? Keep repeating these values, then it will become a habit. You need not think it is all you'll read during your CRRI time. No. Now itself you try to understand the normal value, when it is abnormal, how to interpret. Okay. Next important investigation for this patient is liver function test. You have to look at the patient's bilirubin, transaminases, SGOT, SGPT, and then alkaline phosphatase. I'm sure in your biochemistry class and also in a medical ward, they would have explained to you in a patient with obstructive jaundice. In this patient, for example, with a bile duct stone, they'll have the direct bilirubin will be raised, normal or near normal SGOT, SGPT, but they'll be having a grossly increased alkaline phosphatase. Okay. And if they have inflamed gallbladder like acute cholecystitis or infection, C-reactive protein will be increased. When a case of obstructive jaundice, because bile is important for absorption of fat-soluble vitamins. Vitamin K is a fat-soluble vitamin. So whenever you have a bile duct obstruction, like bile duct stone, there will be a malabsorption of vitamin K dependent, okay, things. So because of that, the vitamin K is not there. So vitamin K dependent coagulants will not be produced. So patient will have prolonged what? The prothrombin time. So that is called INR. Okay, international normalized ratio. Normally it is 1 or 1.1. If it is more than 1.5, then you have to give these people with a gallstone disease an important injection. That is vitamin K parenterally. Because if you give enterally, it needs presence of bile. In a patient with the bile duct obstruction, the vitamin K will not be absorbed. Okay, so you need to give them parenteral vitamin K IV 10 milligram in adult. Right. Okay, this is a radiological. What is in the radiology? Plain X-ray, ultrasound, CT scan, MRI, MRCP. These are all the, in other words, it's going to be very busy investigation as far as the bile duct stones are concerned. Let us start from something simple for undergraduates. That is plain X-ray. If you see, whether you will be able to see the gallstones, if they ask you in the exam, you tell. The gallstones are predominantly radiolucent. In other words, 80% of the gallstones are radiolucent. That means they will not be seen in the X-ray. Only 20% will be seen. That's why we say 20% rule. Why it is important? Because in kidney, just opposite. Most of them are radio opaque because calcium oxalate stones. Calcium is there. In the presence of a lot of calcium, renal stones are radio opaque. So 80% of the renal stones are opaque, whereas 80% of the gallstones are radiolucent. That is a very important statement. Here is a rare 20% case of gallstone. And here is a one unusual gallstone disorder where there is a calcification of the gallbladder wall. That is called, anybody? Right answer. This is called porcelain gallbladder. Porcelain gallbladder is a very important spotter for you. X-ray, radiological spotter. Whenever you have the side, the right upper quadrant, something like a bag with a thing like this, there are only 2 or 3 things. In your opinion, my opinion, there are 2 things you can always tell the examiner. It is in the region of the liver sac. So only 2. One is a porcelain gallbladder. Next is a calcified hydatid cyst wall. If you say either of these 2, undergraduates, you pass very easily. Okay. What about ultrasound? Ultrasound is the investigation of choice for gallstone. Okay, this is the most important investigation as far as the gallbladder stones are concerned. So this is the very classical picture all of you should start visualizing. This is the grainy appearance of your liver. And within the liver, you see this filled with a dark. This is a fluid bile. So this is a thin-walled gallbladder distended with bile. This is bile, in which you have a bright echoic shadow. This is a stone. One means single large stone. If similar one, multiple stones. Here, for example, hundreds of small granular things. Say are nothing but a biliary sludge. Sludge is nothing but a tiny stones. Okay. Okay. Here it is a large stone. Whenever you have a large stone, the ultrasound wave will not be able to pass beyond the stone. So beyond this stone, there won't be any wave going. So that's why it causes acoustic window. In other words, there is a brightness of stone, and beyond the bright stone, there is a darkness, the shadow. In other words, it's imagine you are standing there in front of the light, and behind you will be bright, and behind you there will be darkness, your shadow. So you are bright, that is, the stone is bright echo, and behind the stone there will be acoustic window. That's why called acoustic window, post acoustic window. All those terminologies are not only for a sonologist. It should be also when you are seeing the report, try to get all these findings, because those, if you explain to the surgeons or examiner, they'll appreciate that you understand all this terminology like any other clinician. Okay. The next important thing is we always look at the bile duct also. The size of the bile duct is important thing you need to look for. And 6 millimeter is a normal bile duct. Anything above 6 millimeter is a dilated bile duct. A dilated bile duct means stone is there, indirect evidence. Sometimes you'll be able to see a stone, but the most important indirect evidence you should understand. Okay, so this is the rule of 6. Have you seen 6 number anywhere? A bright students, you may know, I told you toxic megacolon. The transverse colon can get distended more than 6 centimeter. Okay, so there 6 centimeter, here 6 millimeter. Okay, and pseudo pancreatic cyst, I'll come in a minute, the next class. There I'll tell you 6 weeks. If cyst is there for more than 6 weeks, you have to operate. All this magic 6 numbers. And also aortic aneurysm, if they are more than 6 centimeter, they rupture. So you have to operate on the aortic aneurysms. So these are all the correlation, the power of correlation you have to understand. Okay, and if you have a biliary pancreatitis, the pancreas also will be swollen. So ultrasound gives you a lot of information, and that is why it is important. And what other investigations we can do? I told you CT also helpful, because in CT abdomen is very, very important for all acute abdominal condition of our body. CT abdomen is very important condition for staging up all abdominal malignancy or malignancy anywhere in our body, because CT abdomen, I told you in the last few classes, gives you the TNM staging. If you ask you why it is important in oncology, sir, it gives you the stage of the tumor, size of the tumor, T stage, nodal spread, N stage, and metastasis like liver spread and things like that. So TNM, that's why it is important. Next, in acute abdomen, the whole abdomen is seen. So you will very easily see, for example, here you have a cross section. Now, liver is there in the right. See, always you have to imagine the CT abdomen. You are standing and reading from the foot end of the patient. So this is patient on the right side. This is patient on the left side. Okay, don't say, okay, how do I know? This is liver, this is spleen, this is right kidney, left kidney, this is aorta in front of the vertebra, this is the inferior vena cava, these are bowel loops. Okay, this is like a little omentum fat, this is anterior abdominal wall, lateral abdominal wall musculature, like external oblique, internal oblique, transversus abdominis muscle, and skin. In between the skin and muscle, fat. If you are very fatty, this darkness will be very thick. Like for example, this patient is having a lot of fat here, less fat here. Okay, so all these things you can see. All the muscles also you can see. Okay, the posterior spinal muscles. Right. Let us concentrate on this is the gallbladder, and this is the gallstone. Gallstone, multiple gallstone with a distended inflamed gallbladder. Here, another patient, not only the gallbladder distended, in between the gallbladder and liver, there are some air packets. Okay, you don't see air within the gallbladder wall. Okay, here it is not gallbladder inside, it is not pneumobilia. Pneumobilia is air in the biliary tree. Here, the air is actually, the dark thing is air. Air is within the gallbladder wall. That is called emphysematous cholecystitis. Emphysematous or gangrene. Any gangrene, okay, like Clostridium welchi causes gas gangrene. Like that, here also some organisms, gas producing organisms, can give rise to emphysematous cholecystitis. Quite common in a patient with diabetes again. Diabetes is notorious to give rise to life-threatening complication. Okay, so you get so much of information from your ultrasound, CT, and also another important investigation is MRCP. I'll tell you in a minute. Before that, I'll explain to you 2 unusual conditions you have to understand at this stage also. What are the unusual conditions? I told you already. Patient, when they have gallstone, they develop biliary colic. But sometimes they can have a silent stone, that is called stone without symptom. For example, you are aged 40, you are going for what I call a master health checkup. Just check up. You never had biliary colic, and the sonologist find you your gallbladder having a 2 stone. Now you are worried whether I need to have my stone removed, because you are asymptomatic from the gallstone. That is one condition. Okay. Another condition I'll tell you. Patient comes to you with a severe right upper quadrant pain. You do an ultrasound. There you don't see a stone, just inflamed gallbladder. that is called acalculous cholecystitis. So now it brings to an important other entity. Cholecystitis can be calculous cholecystitis, acalculous cholecystitis, emphysematous cholecystitis. Okay, let us go. Calculous cholecystitis is stone in the gallbladder causing infection. That is the commonest thing. Next is acalculous cholecystitis is bile can get infected without the stone, common in diabetes. Emphysematous cholecystitis, same diabetes people can give rise to this problem. Okay, and there is one more rare condition called biliary dyskinesia. Okay, in other words, whenever there is a spasm in the sphincter of OD, then it causes some pain in the right upper quadrant, that is called biliary dyskinesia. This is a postgraduate heading, but at least you have to understand these rare terminologies. Okay, right. And this is just a summary of all the investigations. Just now I told you, whenever you have a patient with the gallstone disease, hematological, biochemical, amylase level, radiological, all these things we have done. Now we have to treat the patient. Any patient with the cholecystitis, you have to remove the gallbladder. Like anybody with appendicitis, what we do? Appendicectomy. Anybody with the cholecystitis, inflamed gallbladder with the gallstone, what we should do? We have to remove the gallbladder. So cholecystectomy, either laparoscopically or open. But sometimes if they have in addition to the gallstone in the gallbladder, if they have a stone in the bile duct, you have to remove that stone also. For that, we do a procedure called ERCP. So in the next subsequent slide, I am going to tell you about the laparoscopic cholecystectomy and also ERCP. So I'm going to just stop here because we have about 35 minutes or so before we conclude. So I'll just stop sharing for the time being, allow you to interact, just to avoid the monotony. If any questions or any clarifications, please unmute one by one. Ask me. Gautam. Yes. You want to ask me something? You can. Mokana, Monica, Soumya, Nelsie, Kumar, Bharat, Jagan. All welcome. Saranya, Monisha, Akshay, Selva, Harini, Samhita.
Hello, sir. Good evening, sir.
Yes.
Akshay from Akshay from Government Medical College, sir.
Yes, Akshay. Tell me. Ask me.
Sir, do we have any role for upper GI endoscopy in gallstone, sir? Do we have any role?
Yes, very, very good question. This is actually not for you as an undergraduate, but as a clinician. Any upper abdominal pain, when you have gallstone, is only one of the causes. So you can have a dyspepsia, ulcer dyspepsia, biliary dyspepsia. Gallstone causes biliary dyspepsia. For that, you do an ultrasound. But a differential diagnosis for gallstone dyspepsia is ulcer dyspepsia. For that, you have to do an endoscopy. So if you write in the investigation in your algorithm, just now I mentioned, an upper GI endoscopy to exclude whether the patient has an ulcer disease, it's very, very important question. I mean, I think investigation, and everybody will appreciate your answer. Absolutely, you're right. It is important investigation.
Thank you, sir.
Right. Anybody else? Chat box, let me see. Anything else? So, porcelain gallbladder, I think we have already explained to you. Porcelain gallbladder is very rare conditions where there is a calcification of the gallbladder wall, and you can see that in the plain X-ray. Here there are only two things you should know. One, it is a precancerous condition for gallbladder cancer, number one. Second, laparoscopic cholecystectomy may be technically difficult because very, very difficult. It's a hard gallbladder. So open cholecystectomy, that is conventional open surgery, may be required. Okay. And a biliary colic, why it is called a misnomer? Very difficult because biliary colic is such a common word. It's like a renal colic. See, people say it's a renal colic. Ideally, what kidney never contracts, isn't it? It is a urinary colic. So the stone in the cystic duct or stone in the bile duct only actually causes pain. Stone actually in the gallbladder never causes pain. It is a misnomer. But biliary is a terminology. Any biliary disorder will present, especially if there is an obstruction anywhere, causes a colicky pain. So any colicky pain in the right upper quadrant, classical radiation to the right shoulder tip with the vomiting is described as a biliary colic for hundreds of years. So I won't call it as a misnomer, but it can happen not only because of the gallstone disease, also because of the CBD stone. Okay. Gallstone pancreatitis we are going to discuss next week, because pancreatitis itself is a big chapter. But the main thing is, unlike the pain in the biliary colic, pancreatitis pain will be how? It will be severe upper abdominal pain radiating right through the back, and the patient will be very sick and will have what I call a hypovolemic shock, because they will be having a very severe shock, that is a hypovolemic shock. It is a retroperitoneal inflammation. So because of that, you have to imagine 30% of your body extracellular fluid loss. So patient will be having tachycardia, hypotension, two cardinal signs you will elicit in pancreatitis, in addition to the Murphy sign you see in your acute cholecystitis. Okay. And why you don't remove the gallstones, why you want to remove the cholecystitis, that is a very common question. Patients ask me. I'll tell you in a minute, because we are going to discuss cholecystectomy anyhow. Okay. And pneumobilia is air within the bile duct. Emphysematous cholecystitis is air between in the gallbladder wall itself. Okay. Whenever you have a within the wall or just outside the wall of the gallbladder, we have air packets, that is called emphysematous cholecystitis. Whereas pneumobilia is air inside the bile duct, especially. That is two different conditions. Which is emphysematous cholecystitis much more lethal. I told you pneumobilia can be asymptomatic. Very often you see only radiologically. Okay, any other questions? Otherwise, we'll go to the chapter now, and we have only about 35 minutes. Rajaram, are you still there? Okay, I hope you can see the slides again now. Can you?
Yes, sir, I can see.
Ajam, is the slides back normal?
So it is not in full view, sir. I think so.
Well, let me just say, that's why I wanted to verify. The bottom part, yeah, now?
Not yet, sir.
Can you see the slides? No? Yes.
Yes, sir, I can see.
What slide you are seeing? Open chole versus lap chole?
Yes, sir, that's right only. Sir. Full view, see, sir.
Okay, fine. Okay, students, for the next 15 to 20 minutes, we are going to see the another important chapter, that is the difference between the lap chole and open chole. See, here is a procedure which we used to do for the last 100 years. That is, whenever you have a patient with the inflamed gallbladder, acute cholecystitis or gallstone, we do a right subcostal incision, otherwise called Cocker's incision. K-O-C-H-E-R, Cocker's right subcostal incision. Retract the abdominal wall, expose the gallbladder, and ligate the cystic duct, and then remove the gallbladder along with the stone. Nowadays, we don't do this muscle splitting incision. We just make a tiny incisions, 3 or 4 incisions, pass the telescope, visualize the gallbladder, and dissect and remove the gallbladder like a bag along with the stone. So the trauma, because of all these incisions, are so minimum. This is relatively a pain-free procedure compared to this procedure, where because of the large incision, it is very painful, and because it is just a right subcostal region, patient will not also breathe after surgery. So they'll have a lot of problem with the respiratory complication. Okay. So all these things are absent in this case. Okay. So laparoscopy is by far nowadays an established way of removing the gallbladder. In other words, in the last 10 years, if you ask me, 99% of the cholecystitis are managed by laparoscopically. Open cholecystectomy done only in people who are unfit for laparoscopy. It is so demanding because people, okay, It is all just awareness is so much. Everybody wants laparoscopic surgery. The laparoscopic surgery is always called video assisted surgery. It has a telescope, a video processor, and a carbon dioxide insufflator, and energy sources. There are a lot of instruments are required. They are all placed in what I call a laparoscopic trolley. So in addition to the all conventional instruments, in laparoscopy, we need a trolley which is having a video monitor with a lot of processors. Okay, processors. So what are the things, essence of laparoscopy? It depends upon the technology, that is video assisted technology. That is, you look at the monitor and operate. You don't look down, look at the patient's abdomen and see. Okay. Second, technique. You make keyhole incisions, 3 or 4, 5 to 10 mm incisions. Through that, you pass all these small instruments, long instruments, and operate. That's why it is otherwise called keyhole surgery, video assisted surgery, or other alternative terms. And it is not a single person. I have to operate. My assistant will hold the camera. The staff nurse will help me. Anesthetist will be at the head end. At least 4 people. It's like a teamwork. What is the advantage of laparoscopy compared to the open surgery? Commonest question for undergraduates. So you should not. So if you have surgery with some tiny incision like this patient, next day you have surgery on Saturday today, tomorrow morning you are up asking for a cup of coffee. Monday morning you are going for a walk. Tuesday you are going in the car. And Wednesday and Thursday you are going back to work like you are IT person. So very little pain because there are small wound. So pain is less, and wound related complications like wound infection, all these things are less. And like wound infection is very common, especially when you have a long incision. In the era of laparoscopy, wound infection is minimized, and also hernia, incisional hernias are less, all those things, wound related, all complications are less. Third important thing is early return to normal life. Stay in the hospital is a matter of days, 1 or 2 days. In a conventional operation, you tend to stay for 2 weeks. Here only 2 days. And back to work by 2 weeks here in laparoscopy. In an open surgery, 2 months you take leave, isn't it? So that's the difference. You should be able to tell the examiner very clearly the difference. Let us take you to various steps of laparoscopy, especially in a case of gallstone. The first thing is, all patients for laparoscopy, they have to undergo under general anesthesia. I'll tell you why general anesthesia. Unless in a hernia surgery, like last class we did hernia, or even gallbladder, when you do for open gallbladder, we do a spinal anesthesia. But here, laparoscopy is preferably done under general anesthesia. Because why? Because carbon dioxide, which we use for creating pneumoperitoneum, has to be expelled only by the patient's lung. So you have to hyperventilate. You have to have a control of the patient's lung. So general anesthesia is preferable to have a watch on the patient's hypercapnia status. That is, you don't want the patient's carbon dioxide level in the blood to rise unnecessarily too high. So for that, you need to preferably have a patient under general anesthesia. Okay. And what is the first foremost step in laparoscopy? You should say that at the level of the umbilicus, we pass a spring-loaded needle called Weyer's needle in order to safely enter the peritoneal cavity, because this spring-loaded needle ensures that you enter the peritoneal cavity without causing any damage to the bowel, bladder, or blood vessel. 3 B's. What are the things? It will not hit the bowel, no perforation. It will not cause damage to the bladder. Okay, it will not cause any bleeding unnecessarily from the blood vessels like aorta, IVC. So it is fairly safe because blunt tipped, not like your venflon, which is a sharp end, isn't it, at the end? So safe entry. And what you do, you attach carbon dioxide, and with the pressure transducer like the automatic insufflator, you put inside carbon dioxide. Why don't you put oxygen, if you ask me? Because carbon dioxide is cheap, safe, and easily absorbed in the peritoneal cavity and easily expelled from your lung, unlike oxygen. Oxygen, in addition, it is explosive, isn't it? because inside the abdomen, we are going to use some energy sources like a diathermy. So that causes some fire. That fire explosion hazard is a problem when we use other gases like oxygen. Okay, it is not so with the carbon dioxide. So don't use nitrous oxide, don't use oxygen, use only carbon dioxide or argon gas. Argon gas. Okay. Next, what we do? So, in other words, we put the virus needle, inflate the peritoneal cavity like a bellow or a balloon. So, your abdomen is now becoming like a 9 months old pregnant lady, big abdomen, in which you make tiny holes, okay, like this small holes, 5 mm holes, through which you pass this port. These are all called trocars, like your size of your index finger, okay, breadth of your index finger. You just insert inside. Through this, you insert some hand instruments. See, they are all instruments. They are nothing but miniaturized open instruments. See, like artery forceps, cutting scissors, hook. So all these instruments are so minute, they can go through these minute openings you made, like 5 mm holes. And how you are able to see what's happening inside the patient's peritoneal cavity? By passing a telescope. So this is called a laparoscopy. Okay. So if it is going inside the peritoneal cavity, it is called a laparoscopy. If it is going inside the chest, it is called a thoracoscopy. It is going into the bladder, that is urinary bladder, cystoscopy. So depending upon, so all these are rod lens system. Okay, it is too much for you as an undergraduate, but at least you should know. Thanks to Hopkins. Hopkins is a person who invented this rod lens system, which gives rise to a clear transmission of the image to the eyepiece. And if you attach a camera to this eyepiece, this image is taken into the processor and it is put it in the monitor, high definition monitor or a 4K monitor. Okay, and how you are able to eliminate the peritoneal cavity, how you are able to throw a light, because there is a side view here. Here you put a light piece and you attach usually what we call a xenon light. Xenon is a light which is a white light as good as a sunlight. So you put the xenon light, you put the camera here and you watch the whole procedure like this. I am watching the peritoneal cavity now, and you are now along with me watching the right upper quadrant of the patient's body. Here what you see here is a gallbladder. I am putting another instrument, trying to put in the fundus of the gallbladder, trying to push it up, retract it. And I am using another instrument here and like a curved forceps, and I am removing all the fat, yellow color. These are all momentum from the body of the gallbladder. I am just pushing with this, retracting the gallbladder. Liver, gallbladder, momentum, dissection is going on. Everything you are able to do. See, I am operating with the 2 hands like this. Okay. And what is happening next? Then I am going to dissect this portion of the gallbladder. That is the place where the cystic duct, cystic artery are present. The bile duct is also present. That area is called a Callet's triangle. If you know Callet's triangle is enough. This is Callet's triangle for you. That is cystic duct, common hepatic duct, under surface of the liver forms a triangle. And if you do a dissection in this triangle, you invariably find cystic lymph node and also cystic artery. Cystic artery is the artery of the gallbladder, which you have to ligate. Cystic duct is the duct you have to ligate. Then you remove the gallbladder without spilling the stone like a pack. So we are removing all the fat, see, and also we are using some energy sources. So here there is a hook-like instrument which is applying a diathermy. There is a monopolar current, and you are doing a remove just slowly, millimeter by millimeter, using this diathermy. See, this is the diathermy machine. We are using it to do the surgery. So when you do that, then you will be able to see the content of the Callet's triangle. That is cystic artery and also the lymph node in that region. And once you are able to see the cystic duct, that is a greenish structure like this, here the cystic duct, then you will be able to ligate this cystic duct and remove it. So this is what we are about to do. See, for example, next thing, if you see here, if you want to know what I am dissecting is cystic duct, where is the bile duct, whether the patient has any stone in the bile duct, we do one procedure during the operation itself that is called intraoperative cholangiogram. They'll ask you rarely this question nowadays. What is peroperative or intraoperative cholangiogram? It is nothing but whenever we suspect there is a stone in the bile duct, or whenever we suspect there is some anomaly in the anatomy of the bile duct, we can take a picture or we can make a road map of the bile duct by injecting a contrast, by putting a catheter into the cystic duct. See, cystic duct, you put it and the contrast is injected. You are able to see the right, left, and common hepatic bile duct. And the bile entering the second part of duodenum. There is stone, no stone at all. So this is what we call an operative cholangiogram. Nowadays we don't do, because before surgery itself we got all the information. Okay. But if you do, you finish that, then we do, once we put some clips like this. See, we have a special metal clip, no ligatures. We can put some clips, then apply here, then you cut the gallbladder, divide the cystic artery, then remove the whole gallbladder without any spillage of the stone, take it out through the same small hole you made it. So that is a cholecystectomy. So I am just about to apply one clip, then apply few more clips, cut in between the clips like this. Okay, see, this is the way surgeon. So what is the advantage of this surgery compared to the open surgery in of itself? For the surgeon and also for all the people in the OT, they can have a clear visualization of the anatomy without much struggle, because everything is magnified, everything is like a monitor, high definition monitor, and you are able to do assisted by the video. So it is a video assisted surgery through a keyhole you made, but it needs a very good hand-eye coordination, your hand and your eye coordination. So it needs a lot of practice, but eventually you get over this, what we so called, see, this is a cystic duct, okay, and you will be also able to see the cystic artery just began. This is the cystic artery. So cystic duct and cystic artery, okay. And what we do, then you divide. So we have a scissor also, and you divide the cystic duct like this, okay, and also artery. So once you have done that, so what you do, you remove the gallbladder, and then you take it, hold it like this, the fundus or the cystic duct like this, and remove through the one of the ports. You made 4 tiny holes. One of the holes, you just take it through that. See, you see, there is no spillage of the stone. Like that, you just remove, and all the fluid inside you can remove. See, all this fluid will be removed, the stones will be removed, and it will be, that's the operation is over. So you now had witnessed a glimpse of how a laparoscopic cholecystectomy is done. Okay. See, like that you can do. What about the open surgery? I told you, unlike laparoscopy, here it is a spinal anesthesia. But where open cholecystectomy is done, at your level you tell, whenever there is a patient is unfit for general anesthesia. Second, if there is some difficulty during laparoscopy like excess bleeding or anatomy is not clear, the surgeon is not happy, then he'll do what is called conversion of laparoscopic cholecystectomy to open cholecystectomy. So failure of lap chole or unfit for general anesthesia. These are the 2 indications. Third, you can add unusual conditions like a porcelain gallbladder, because there it is very difficult to do a laparoscopic cholecystectomy. And then you make a subcostal incision, and then you expose a Callet's triangle, then you remove. What are the complications of the cholecystectomy, whether it is open or laparoscopy? The one important complication you should understand is injury to the bile duct. That is the most important complication you should all understand. Okay. So that finishes the cholecystitis laparoscopic cholecystectomy. The last 10 minutes, I'll tell you some important things regarding the bile duct stone, because sometimes can be asked as a short notes, and there are 2 important triads and pendants, you know, the CBD stone, short notes. One important statement I hear itself I want to make for all of you is the mother of the gallstone is gallbladder. Okay, whenever you see a stone in the bile duct, you have to imagine in your mind that stone is actually coming from only gallbladder. Primary bile duct stone is very rare in our country. It can happen secondary to some infection, especially in some Southeast Asian countries. 10% of the people will have combined gallbladder stone and also bile duct stone. And this is Charcot's triad. I told you already. Intermittent pain, intermittent fever, and jaundice is Charcot's triad. Reynolds Bender, in addition, if you have cholangitis, you can have hypotension, unconsciousness, or confusion. Sometimes it is one of the common differential diagnosis. There are only two common conditions for obstructive jaundice. Okay, one is gallstone disease, bile duct stone. Second is a carcinoma head of pancreas. Okay, and biliary pancreatitis is another condition. Rarely, bile duct stone also can present asymptomatically. And how will you know? Only by doing an ultrasound imaging. And I told you already, a patient with obstructive jaundice will have direct bilirubin will be raised, alkaline phosphatase will be raised. These are the two cardinal biochemical abnormality in any patient with obstructive jaundice. What about patient with hemolytic jaundice? I'll tell you now itself. People, very bright students here, you just see what I'm telling is right. A patient with the hemolytic jaundice will have indirect bilirubin, it will be marginally raised, and they'll have normal HGOT, HGPT, normal alkaline phosphatase. They'll have urine urobilinogen will be high, and also they'll be having anemia. So that's why we always say patient with anemia, jaundice, you suspect patient is having a hemolytic anemia. Okay, what about hepatitis, like a viral hepatitis A, B? How will they present? They'll have raised bilirubin. Here, both direct and indirect will be raised. They'll have SGOT, SGPT very, very high in thousands. That is a classical viral hepatitis. Alkaline phosphatase is often normal. So these are the three classical things. Okay, just go back tomorrow if you are not able to recollect today to the YouTube recording of the same and try to recollect. They'll ask you, and you make a small chart. Okay, bilirubin, direct, indirect. Next is SGOT, SGPT, alkaline phosphatase, urine urobilinogen, and hemoglobin. All this is a single chart. Hemolytic, hepatic, and obstructive jaundice. What are the findings? You should memorize very clearly without any, confusion. Okay. What about the radiological investigations? There are handful of investigations for bile duct stone. Like I told you, ultrasound abdomen is useful, but not very sensitive. CBD, if it is more than 6 millimeter, I told you rule of 6, it is sign of bile duct stone. But what is important is sometimes we do an endoscopic ultrasound. What is endoscopic ultrasound? This is endoscopy with an ultrasound at the tip of the endoscopy. So you take the ultrasound machine inside the patient's body. Very unusual. It is done in few centers, not everywhere. And it is very, very good in identifying the bile duct stone. But it's not a common investigation in our country. What is common in our country is MRCP. What is MRCP? It is nothing but magnetic resonance imaging of the biliary and pancreatic tree. So MR of cholangio and pancreatic tree. Magnetic resonance cholangiopancreaticogram, MRCP. So it is not MRCP, the degree. MRCP degree is also there, like FRCS, MRCS. Okay. But what about ERCP? When MRCP is an investigation of choice or a test of choice, ERCP is a treatment of choice. Here, a special endoscopy, this is actually called a duodenoscopy, is passed inside the patient's mouth. And it enters, okay, into the second part of the duodenum like this. and you are able to see the ampulla vater. How it is possible to see the ampulla vater? Because it is a side viewing duodenoscopy. You are able to see the ampulla vater like this, and you are able to take an X-ray of the bile and pancreatic duct, and also you are able to do some therapy. So it is the endoscopic visualization of the upper GI tract, radiological evaluation of biliary and pancreatic system, and also you are able to do various therapeutic procedures through the ERCP. So you should be able to tell something about ERCP even if they ask you in Viva. ERCP, it is a 4-letter word, and also it is having 4 important people involved in this as a teamwork. Endoscopist like me, radiographer with a C-arm, so it is done in the theater, anesthetist in the head end to take care of the patient, nurse to help me. So all 4, we try to enter the duodenum, and through the special accessories, we are able to take a picture of the bile duct, pancreatic duct. What is the difference between the bile duct and pancreatic duct? The pancreatic duct will go right across the L1 vertebra. See, this is T12, this is L1. So the bile duct, it goes right across across. So this is the head, body, and tail of pancreas going right across. This is on the right side of the vertebra, right upper quadrant. So right hepatic, left hepatic duct, gallbladder, cystic duct, common bile duct, common channel, and sphincter of body, where the duodenoscope is going and just cannulating. Okay, so this is the procedure. So this is the instruments we use for the cannulation, and this is the way we just enter the bile duct. We make the hole little bigger, that is called a sphincterotomy. Then we can pass a balloon inside the bile duct, inflate the balloon, and as you drag the balloon, any stone or sludge, if they are below, it can be easily removed. Okay, this is called a balloon sweep. See, the same principle only we use for also for removing the embolus in blood vessel. That's why it's called Fogarty catheter, Fogarty embolectomy, or Fogarty balloon sweep of the bile duct. Here it is a Dormia basket, like urologist, they have something like a fish net. So it's a wire net is passed inside the bile duct. You open the basket, grab the stone, and bring the stone out. So these are the various things. So here is a one-way picture or video, small video, just to show you. We are enlarging the bile duct by a sphincteroplasty like this, with a balloon sphincteroplasty. So after that, what we can do? We can remove that stone, can drop through the hole which is made. Then either you can pass either a balloon, like a Fogarty balloon, or a Dormia basket, grab the stone or drag the stone. So the stone is dropped outside like this. See, very easily you can remove the stone without an operation. So everything is done through the mouth. It is the, endoscopist can treat the gallstone problem without even making a incision. So it is better than laparoscopy in that way. So here is a real another patient. This patient with obstructive jaundice. We did a cholangiogram. Now this is the ampulla vater, periampullary diverticulum. I am putting a small catheter and making the hole little bigger. That is called a sphincterotomy. Sphincterotomy is nothing but division of the sphincter muscle. I told you sphincterotomy is same sphincterotomy methodology only we are using also for procedures like a achalasia cardia. You know what we did, okay? And also we do a same procedure like a Ramsted's procedure. Sphincterotomy here, episiotomy or internal sphincterotomy for a fissure in ano. So these are all where we divide muscles in surgical conditions. Okay. Now what I'm doing, I'm passing a small balloon inside, inflating the balloon like this and pulling the balloon outside. As I pull, it'll drag the stone and remove all the stone. Maybe 1, 2, sometimes even 10, 15 stones can be removed. See, one stone is coming now. So you'll be able to visualize very, very clearly. Okay, we are just in the last 5 minutes of our discussion now. So sometimes if the stone is removed, the bile duct, and after that, if the patient has some problem, complications of laparoscopic cholecystectomy is, sometimes you remember what I did for the cystic duct, we put a small clip, isn't it? That clip can dislodge in some people, then they can have a leakage of bile, that is called a cystic duct leakage of bile, causes bilioma, biliary collection. In such patients, when they come, we need not operate. We just take the patient endoscopically. I can put a small tube, stenting, and help the drainage of the bile this way and treat this condition. So ERCP is not only helpful for removal of the stone, but also it can helpful for complications following laparoscopic cholecystectomy. Okay, and rarely we do a procedure. I told you already in the beginning. Yeah, choledocholithotomy, and also choledocholithotomy. So here is one important thing. See, for example, here it's a video: gallbladder, cystic duct, bile duct. So laparoscopically also you can see. I am just squeezing the cystic duct. Then we pass. There is a small stone just came out. Then through this we put a small cannula. Take a picture of the bile duct, that is called a peroperative cholangiogram. See, like this, you inject contrast. Okay, urographene is a contrast. You can see the nice view of the bile duct, and there was one small stone there. So what I'm doing, I'm using a small telescope inside telescope. So this is called choledocoscope, in going inside the bile duct. That's why it's called choledocoscope. And it's seeing a stone. I am catching the stone. Then you can take the stone out. So these are all the high-end specialist technique, but at least you have the opportunity to at least understand and witness at your stage. So this is a way we remove the stone. So even deep inside the bile duct through a flexible choledocoscopy while you are doing a laparoscopy and a peroperative cholangiogram. Okay. Sometimes we do also a procedure, anastomosis of the bile duct to the duodenum, bypass procedure, especially when there is a stricture of the lower end of the bile duct. Then I can do a procedure called choledochoduodenostomy. So it's very easy if you understand, joining the bile duct to the first part of duodenum, because I told you already the bile duct is supraduodenal and also goes behind the duodenum, retroduodenal. At that place, you make an incision in the bile duct, incision in the first part of duodenum, join them. So the bile will be going here rather than going through the ampulla vata, because ampulla vata is having stricture. So in a stricture of ampulla vata, we can do this. That is called choledochoduodenostomy. So these are all the various procedures we do. And this is the last thing, that is, I already told you, a stone right here at the end of the bile duct here can cause reflux of the bile from the biliary duct to the pancreatic duct, causes gallstone pancreatitis. In those conditions where there is a stone at the ampulla vata, we can do something like an episiotomy, just divide that sphincter and deliver the stone, and the patient will be relieved of the pancreatitis very quickly. So this is one procedure. See how simple, just 1 minute we are able to go see, and the stone is delivered. See, the stone is out, the bile will be draining, just a stone, just give a tap and it will be dislodged. Okay. So students, the take home message for all of you now. Okay. Gallstone disease gives you a wide spectrum of disorders, 10 different pathology, starting from biliary colic down to the gallstone pancreatitis. Pancreatitis is one of the important thing. Apart from alcohol, gallstone also causes pancreatitis. Next important sign of cholecystitis is Murphy's sign. Remember, how will you elicit Murphy's sign? Examine in a patient, try to explain to the examiner without any hesitation. Charcot's triad, Raynaud's pendant. Lap cholecystectomy, you should be able to tell clearly because you have seen an operation just now. ERCP, what is that? It is procedure, endoscopic procedure using a special side being duodenoscopy in order to remove the stone in the bile duct. Okay, so these are all the summary. Now, before we go in for our thing, let us have some questions. Last few minutes before we go. Rajaram, you can, all of you can mute, unmute everybody, ask all to unmute. Okay, Anuskita, again you are asking a question.
Sir,
Tell me, yes,
sir,
yes, go on.
sir, post-operative advice, sir, for cholecystectomy.
Yes, post-operative advice for patients after laparoscopic cholecystectomy and open cholecystectomy. Let us take one by one. In a patient with laparoscopic cholecystectomy, if a patient is having a surgery like today, they usually stay in the hospital for 1 or at the maximum 2 days. If they are pain-free, if they have no fever, they'll be able to go home. Then they can have liquid diet from the second day, that is the following day, second day, and they can have a near normal diet, okay, from the third day onwards. They can do household activities or desktop activities, like what you are doing, like me and you. If you are sitting and doing something in the computer, doing something in the kitchen, they can do from day 4, day 5. They can go under in the cycle, or they can go driving after 2 weeks. So normally I tell them 2 days rest in the hospital. After 2 weeks, you back to your work. And during these 2 weeks, wound is so small, you can leave the wound exposed. The wound related complications like infections are unknown. So there is no need for wound dressing, wound care. So this is the advice we normally give for all laparoscopic cholecystectomy. In other words, it is ambulatory care surgery, otherwise called. In open surgery, it is different. Usually they stay in the hospital for 5 to 7 days. They need to take rest up to 2 months. That is 8 weeks from hard, heavy lifting work. Okay, and they have to be nil oral for at least for 2 to 3 days. So it is a gradually only they recover in open cholecystectomy. So the recovery is slow in open, recovery is fast in laparoscopy. Pain is less in laparoscopy, pain is much more in open procedure. So these are all the two different. In both, the important complication you never forget is bile duct injury. However uncommon it is, bile duct injury can happen in 0.5%. In every 200 cases we do, one gallbladder, bile duct can be injured. So what is the sign of bile duct injury? Patient will have abdominal pain and also bile collection, that is biliary peritonitis or jaundice. These are the three cardinal findings you see in patient who had a damaged bile duct. Cause of endotoxemia and cholecystitis because of the gram-negative sepsis. If you have E. coli, Klebsiella, Pseudomonas from the cholecystitis, if it enters, it causes bacteremia. Then it causes a gram-negative septicemia and hypotension. That is called endotoxemia because endotoxin released from this gram-negative bacilli. Okay. These stones can occur in intrahepatic duct, common hepatic duct. Very rarely it can happen. Sometimes the stone in the low down, they can go and float high up in the intrahepatic duct. And also I told you, well, there is a worm infestation like clonorchis sinuses. They can have intrahepatic stones. And there are two other conditions where there are stones can happen. Sclerosing cholangiohepatitis, sclerosing cholangitis, where there is a multiple strictures in the bile duct. They can have stones in the intrahepatic stone. And a Caroli's disease. Caroli's disease is a very rare type of choledoccal cyst. Okay, that is a classification of choledoccal cyst, Todani classification. Okay, and you see the type 5 choledoccal cyst is called Caroli's, C-A-R-O-L-I, Caroli's disease. So those cases, they'll have intrahepatic stone. Okay. How far can the ERCP relieve stones from the bile? Anywhere in the bile duct, whether it is intrahepatic, extrahepatic, anywhere you can pass the. So ERCP is a treatment for all the stones in the biliary system. Okay, it is the first best treatment of choice for stone in the biliary system. So I finished the chat box. Anybody want to ask any other question? Otherwise, we'll quickly go to the top five quiz questions today. Yes, people wait, admit all. Yes, anybody wants to ask? Final two questions, please. Vignesh, Akshay, ask some question, however simple, because unless you interact, very difficult to understand. Yes, Kadiravan, how are you? Nishant, Monica. Okay, let us go on to our quiz questions then. Okay, I'll just share, go back. Rajaram, can you see my slides again?
Yes,
I
sir.
hope. Yes, okay.
But not in.
Now?
Yes, sir, I could see, sir.
Okay. So this is the statements on acute cholecystitis are as follows. I am making 5 statements regarding acute cholecystitis. One is a wrong statement. Okay. Sudden severe pain, right upper quadrant radiating the right scapula is a classical finding in acute cholecystitis. Murphy's sign is present. Neutrophilic leukocytosis, mild or no jaundice. Open cholecystectomy is the treatment of choice. Which is the wrong statement here? Anybody? Unmute everybody. Rajaram, if somebody can answer. Which is the wrong statement? Out of them, which one you think is the wrong one?
Option A, sir.
Option A. Why?
Sir, the right upquadrant pain is seen in the biliary celiac.
The acute cholecystitis also will have a right upper quadrant pain. See, so biliary colic, acute cholecystitis, empyema, mucosal, everything, any gallstone pathology will have pain. But all I told you, 99% of the people with the cholecystitis or biliary disorders, what procedure they undergo? Laparoscopic cholecystectomy. Okay, open cholecystectomy is not treatment of choice. The wording is important. Okay, open cholecystectomy is a treatment in case of failure of laparoscopic cholecystectomy or patient unfit for general anesthesia. Describe the sign. Ultrasound finding. What is your diagnosis? Anybody? This is a prize question actually. This is actually one of the quiz questions, very rare for undergraduate level, but I am sure there are some bright students out there want to give a rough. This is the type of cholecystitis. Just now you said unusual cause where there will be, yes. This is emphysematous cholecystitis. See, there are some white color. They are all nothing but bright echoes within the gallbladder wall. Okay, and also there are some bright echoes within the gallbladder itself. So they are all gas within the wall and also occasionally within. So if it is only here, it is called pneumobilia. But if it is mainly in the wall, that is emphysematous cholecystitis. So this gives you like as if you are opening a champagne bottle and all the floating gas bubbles. So it is, you imagine this is the gallbladder with all this gas bubbles like that. It is a, you have to stretch your imagination. Radiologists are very fond of all this radiological foot signs and all these signs. So champagne sign is a sign of emphysematous cholecystitis in ultrasound. Okay. The next important thing is match and snatch. This one is easy for you. Anybody wants to try? Yes? Who wants to try? Introduce yourself. You try to compare. CA125 in which pathology? Like that, you just keep choosing one after the other.
Sir,
Yes.
Saranya from Government Year Medical College, sir.
Well done, Saranya. Let us see how you are able to get 80% or 100% right. Go on.
CA125 in case of ovarian cancer.
Good.
PSA in case of prostatic cancer.
Well done.
CEA in case of CA colon.
Very well done. You are nearing there.
Alpha fetoprotein in case of hepatoma and CA19-9 in case of gallbladder cancer, sir.
See, very easy. So this is the way. In other words, some people, one of you may be now wondering what is CA 19-9 if you haven't joined the earlier. So all other things. So you start from what is sure from you, start working slowly. The fifth answer fall in its own place. So this is the way to approach any difficult question. So this is match and mismatch, and this is rightly matched for people. Okay, quickly have a look. So this is another important common type of questions. Name the investigation and what is your diagnosis. First part of the investigation name is easy. This is difficult for your level. Anybody wants to give an answer for it? This is a prize exam, one more prize exam. This is a MRI of the pancreatic and biliary tree. Okay, this is MRCP. This is the right called MRCP. See the gallbladder, bile duct, duodenum, everything is seen like as. Okay, so this is the type of cholangiogram by the MRI. So if you take any picture without endoscopy coming, that is MRCP. If there is a J-shaped or hockey stick ERCP comes, scope comes, it is a ERCP. So only there is two types of. There are three cholangiogram for you. One is a peroperative cholangiogram, preoperative cholangiogram, that is MRCP, then ERCP cholangiogram. These are the three types. Each one will have a different pictures. Keep seeing them. Okay. So the diagnosis here is a pancreas division. To understand pancreas division, you have to go back to your embryology book. Okay. This is the pancreatic duct. Normally, I told you pancreatic duct joins with the bile duct, opens at the ampulla vata. But here, the pancreatic duct, main pancreatic duct actually opens at the minor papilla separately. So this is so in other words, non-fusion of the ventral bud, dorsal bud of the pancreas. So you go and read your pancreas. So this is one of the rare cause for recurrent pancreatitis. Okay, recurrent pancreatitis when they come, pancreas division. How will you diagnose pancreatic division? By doing an investigation called MRCP. Okay. Major complication of lap cholecystectomy. Anybody? Major complication. Which is the right one?
Sir, bile duct injury, sir.
Yes. See, because pneumoperitoneum can happen because anyhow we are creating pneumoperitoneum. Bowel injury, injury liver, injury to hepatic artery happens very rare. But what is important is a bile duct injury. You never forget. This is again a rare for you, but it is now a common investigation. What is this procedure called? See, now you can see the gallbladder and the cystic duct, they all look a different color, isn't it? As if they are blue color. This is actually a laparoscopy. This is the different types of laparoscopy that is called fluorescence laparoscopy. This is actually done the last 5-6 years only. It is now we are commonly do. This is only to color code the. See, you know, everybody now we are doing a color coded surgery. Imagine your blood vessels are, see anatomy when you read, how you read, arteries are in red, veins are in blue color, nerves you draw with a yellow color. Same way if all in real life, they are not like that. Okay, everything is red. Okay, but if you imagine with some contrast injection, if you are able to color various ductular structures, the anatomy is very clearly seen. So here, in order to visualize the bile duct clearly, we during laparoscopic cholecystectomy inject a contrast called ICG, indocyanine green nowadays. So if you give this, it colors the bile duct so that I know exactly where the bile duct. So I will not damage the bile duct. See, that is one way of safeguarding bile duct. So this is the more recent advance. Indocyanine green injection, get a fluorescence laparoscopy or color-coded laparoscopic surgery. Okay. So that finishes today's examination. I hope you understood this very important topic. We covered almost all aspects of cholecystitis, gallstone, bile duct stone, and also laparoscopy, steps of laparoscopy, complications of laparoscopy, and also various benefits of laparoscopy. Just opposite to the open procedure. So that summarizes the whole thing. And next week, will equally important topic for you. Every third or fourth year, they call this as an essay, acute pancreatitis. And the pseudocystic pancreas, important short notes. Okay, so these two we'll discuss next week. And the 10th module onwards, we'll go back again to the clinical modules like varicose vein, foot ulcers, things like that. So I made up modules in such a way, we'll have clinical topics and also the long case, short case topics. So that way we can go equally important topics, and 30 modules, hopefully we'll finish most, if not all of the surgical topics. Okay, so we'll see you. If Saturday, I hope it is okay for me. If it is okay for you, next Saturday, 6 o'clock, we'll meet you all. Okay, if any other questions people want to ask, you can ask, others can leave. Okay, have a nice relaxing weekend. Thank you. I'll be here for another 2 minutes for any clarification. Rajaram, anything you want to tell at the end? Any announcement?
So the feedback link given in the chat box, sir. Kindly I ask the participants to post your feedback by using this link. Thank you.
Thank you. See, people who are joining or your friends, if they want to see, this is same. I think next minute, I think it will be uploaded to the YouTube. There, I'm sure if the clarity, I hope it is equally good. So you can watch that several times. And also you can have the link, like if you put SEM UG Master Class in Surgery, Module 1, Module 2, like that, you'll be able to see any module, and we haven't put any time limit, so I'm sure it will be available for at least next 6 months or so. And I don't think you'll be able to download. If it is a provision to download, put it in your hard disk, by all means you do that. And because nothing like having the whole thing revised just few days or few weeks before with the audio background. So there is no need for you to go back. All these topics, I assure you, you need not go and read again in your books. That there is not at all necessary. You, whatever is said here, you put it in your own words and you just try to understand. That is enough for you. Okay, with that, I thank you all for having assembled on a Saturday weekend, and have a nice relaxing weekend. Bye-bye for all of you. Okay, Rajaram, I'm leaving. I'll see you shortly.
Thank you, sir.